Thank you. Assalamu alaikum wa rahmatullah. Thank you for kind introduction, and I would like to thank Dr. Malik and the other organizing committee and scientific committee for the kind invitation. It's my pleasure to be with you. So my task for today, I'm going to speak about the unexpected bleeding in children in spite of normal initial screening. Actually, the presentation to clinical practice, it's a great diagnostic challenge, especially if the initial screening is normal. So what we mean initial screening, that the BT-BTT and platelet count. So the hematologist play now in this situation a great or crucial role in aiming the further diagnostic and management. Nothing to disclose. So actually the bleeding symptoms and signs in children is one of the reasons to hematology referral, either in emergency situation or even in the outpatient clinic. Usually they start with the standard screening, BT, BTT, and the platelet count, but sometimes it's normal, in spite if there is still symptoms and sign of bleeding. So we have to think beyond of the standard test to see what's going on. In this presentation, we are going to explore the systemical approach to diagnose the bleeding disorder beyond the normal or initial screening test, and to highlight some pitfalls in the either in laboratory result and to diagnose the management principle and when to refer to the hematologist. So why we are concerned about the bleeding? Actually, symptoms can be life-threatening, and it's scaring symptoms for the patient and for his parents. Even though not all bleeding disorders are due to disease process. For example, the nosebleed or epistaxis is one of the common referral reason. And about 90% of epistaxis cases is non-pathological problem under that. So the careful assistance is very important to start with. When we talk about the hemostasis, our very gentle just reminder that it's not only the coagulation, not only the platelet, it's the three phenomena. It react together in very coordinated fashion to stop the bleeding. Start with the blood vessels, and integrity is very important, platelet function, and then coagulation. And we'll not forget also the down bottom of the cascade with the fibrinolytic system. And in the coagulation also to start with the extrinsic pathway with the factor 7 to propagate the other factors, intrinsic pathway, and the end of the consolidate of that fibrous with the react with fibrin and factor 13. So it's when we think about the hemostasis, we think about the primary hemostasis, vascular response, platelet blood formation, and secondary we are talking mostly about the coagulation or clotting factor, which reflected by BT and BTT, fibrinolysis system. So the normal BT-BTT does not rule out all the factor deficiency, does not rule out other problem like the platelet or von Willebrand. So what the test could be, or what the things could be missed with the routine test. So the BT is only reflect the extrinsic pathway. It does not rule out von Willebrand. BTT also intrinsic pathway, but it does not rule out mild factor deficiency or other factor which not reflected by BTT, like factor 13. A platelet count, okay, number, but it does not rule out the function. Fibrinogen measure the function, the quantity, but not missing the function actually. Also, we have to think also about the vascular problem. So to start with assessing a patient with suspect of bleeding disorder, start with careful history, physical examination, followed with laboratory test. So the main thing and very important that the history is very important. It will give you a clue how to investigate and how to request some of laboratory tests. When you start with the history presented with some history of bleeding, you have to ask about, is it only from that side or does he have other side of bleeding? Because it's different with you if it's general or just localized from like nosebleed. He doesn't have other mucocutaneous manifestation of bleeding. Does he have deep bleeding like hematoma or joint bleeding or just mucocutaneous bleeding? So as a physician we can differentiate, is it a platelet problem or is it a clotting factor problem? Even if he has a bleeding after a trauma or after surgery, does that bleeding happen immediately? So again, we are thinking about something like a platelet disorder. Or does the bleeding happen after a few days or a few hours later? So maybe we are talking about the coagulation. So this is all, it guides us as a physician where we go, what more we'll investigate. Of course, the systemic problem and the medication history is very important. Now there is many guidelines in the internet about replacing actually the laboratory test with well-structured questionnaire. So after this question, you can put the scores for the patient if he is really a bleeder or not. Based on that question, also it can direct you what further investigation you do. And this question is well structured, it's not subjective. Like this physician, he will ask this question, the other physician will ask different. It's well structured and it's standard question to rule out or to rule in the bleeding. So after this question and score, you get it, then you get the high probability for the diagnostic test later on. And there is actually scores. There is a scores like for the female scores more than 5, male more than 4, and children more than 3. So based on that, you will guide further investigation. So this questionnaires is very helpful to assess the bleeding symptoms. So to start diagnostic after history and taking the careful question, physical examination, start with CBC, looking for the platelet number, BT, BTT, and fibrinogen. If normal, you can evaluate if really he has a bleeding, evaluate for von Willebrand and platelet disorder. We have the platelet function study, which called BFA 100. This is a screening for initial screening for the platelet function. Von Willebrand factor, antigen, and activity also. Consider or think about connective tissue disease or vascular problem. Don't forget the medication. The medication, because the patient doesn't sometimes know that aspirin is a blood thinner. They don't know steroid also it affects the integrity of the blood vessels and can be easy bruised. So ask about all the medication or other chronic problem. Think about other than coagulation that it may cause risk of bleeding, like inherited von Willebrand disease, platelet disorder like a Glanzmann or Bernard-Soler, surge pool or secretion defect in the platelet, or acquired drug-induced or renal failure, high uremia, or liver disease. Von Willebrand disease is the commonest inherited bleeding disorder, which the prevalence about 100%. It's autosomal dominant. We have other or 4 subtypes of von Willebrand. The most common type is type 1, which about 80% of all the cases. Type 2 is actually dysfunction of the von Willebrand or non-functioning well, and there is also subtype. And type 3, which is the severe type, it's autosomal recessive. We need 2 parents carrier for von Willebrand to get severe, which they behave with the severe bleeding disorder actually. So the diagnosis with doing the antigen and the function and also factor 8. But in von Willebrand you can have normal BT and even BTT. So the normal BTT does not rule von Willebrand disease. It could be normal or mildly low. The tests including the antigen, activity, and factor 8. Multimeres is only very highly specific lab they can do it. And von Willebrand, by the way, you need to do it 3 times because it's very sensitive test. It could be falsely normal, which is with during exercise or during acute hemorrhage or pregnancy. All this it gives you normal reading.
5 minutes, Doctor.
The prevalence of von Willebrand in Saudi Arabia is even higher. And we have also the platelet disorder, as we mentioned. Factor 13, it gives you normal BT, and so we need to test for this fibrolytic system. So we have like this case, 7 years old with recurrent nosebleed, BT, everything it was normal, but von Willebrand it was low, so he was diagnosed as type 1 von Willebrand disease. We have other case, 6 years old with prolonged bleeding 24 hours after tonsillectomy. She had normal BT, normal von Willebrand panel, platelet aggregation normal, so she found that she has surgical cause and management was surgical device and good hydration. We have 12 years old girl with history of epistaxis, and then she got menorrhagia, CBC, BT, normal, so she found to have von Willebrand disease. In spite that she had 2 tests, it was normal, because we said in acute bleeding it could be normal, and 3rd time it was low, and she had more than 2 orifices bleeding. So we have to confirm the bleeding problem and to do the basic screening, and then to think beyond of this normal investigation to find the reason. So there is a more advanced testing like flow cytometry for the platelet, electron microscopy for the also platelet absence of some granules, genetic testing, and referral to a specialized lab may be mandatory. Treat underlying cause is very important. Avoid any antiplatelet drug, local hemostasis, and other modalities. We need multidisciplinary care like ENT, dentistry, hematology, collaboration, pre-operative evaluation, very important, genetic counseling, education and avoid the trauma. When to refer to hematology if there is recurrent mucocutaneous bleeding with normal initial test, if he has any abnormal initial test, suspected inherited platelet disorder, or he need more specialized treatment or management. Rule of pediatric hematologists: interpret all the results carefully correlated to the patient's symptoms and signs, coordinate for reference lab, genetic counseling of the family, pre-operative management guidance. So take home message: normal coagulation tests do not exclude bleeding disorder. Think about platelet function, von Willebrand factor 13, guided by clinical pattern, and target test according to the bleeding pattern, early hematology consultation is essential. Thank you.